Hi everyone. I am going to today discuss about a clinical approach to a case of hemiplegia. Usually in UG students, they commonly keep as a nervous system case as hemiplegia. So most of the students used to prefer hemiplegia case because when you present in a systematic way and when you give a proper diagnosis, it is easy to get through in a case of hemiplegia. So I am now just going to discuss about how to approach a case of hemiplegia. So clinical classification. Stroke is can be clinically classified as progressing stroke or evolving stroke, completed stroke, and transient ischemic attack. Progressive stroke is a stroke in which focal neurological deficit worsen with time. It's also called stroke and evolution. For example, patient may have a weakness in the left upper limb. Few hours later, patient may have a weakness in the left upper limb, and then patient may have a deviation of angle of mouth, and then speech difficult, and then loss of conscience. So, like these, and there is how with hours together, when the stroke progresses, you have to tell it is progressive stroke. Completed stroke, when the patient have a stroke in which focal neurological deficit have completely evolved and persists, and it's not worsening with time, you have to tell it as completed stroke. TAA, there are two definitions. Brief episodes of neurological dysfunction less than 24 hours resulting from focal temporary central ischemia. The new definition is tissue-based transient episodic of episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without evidence of any infarction in imaging. When you take an MRI scan, the patient may not have an acute infarct, but patient might have a weakness. This is called transient, and patient usually recovers faster. It's called new definition of transient ischemic attack. So stroke is broadly classified as ischemic stroke and hemorrhagic stroke. Commonly, it's ischemic stroke. 85% of patients is having ischemic stroke and 15% is having only hemorrhagic stroke. Among ischemic, it may be due to thrombus or embolism. Among hemorrhagic, it may be due to ICH intracerebral hemorrhage or even it may be due to subarachnoid hemorrhage. So ischemic stroke, common almost thrombus is the atherosclerotic thrombus is common about 64%, and embolic like atrial fibrillation 17%, and carotid disease is 4%. Hemorrhagic stroke, intracerebral 4%, subarachnoid hemorrhage 7%. So these are the common cause for stroke. In hemiplegia, now I'm going to differently approach a case of hemiplegia. So mostly I'm going to analyze retrospective because how to write a diagnosis in exam and how to write the corroborative evidence for the diagnosis. Mostly in the exam, what happens, the students will write the diagnosis properly, but there may not be proper evidence in the history taking or examination, so that the examiner think probably you have known the diagnosis and just like that you written the diagnosis. So these type of questions are arise only when you don't go in the systematic way. So I am now going to discuss what are the points you have to write in the diagnosis, and for arriving that diagnosis, how to have to ask any history or how to write, how to do general examination or in systematic examination. Mostly hemiplegia is history based. When you take a proper history, definitely you can diagnose here. Can arrive all the points in the diagnosis in a hemiplegia case. So points. First point, we have to tell whether it is an acute stroke or recurrent stroke or old stroke. For example, the patient is having hemiplegia for the past 2 days. You have to tell it's an acute stroke. And the patient where if they say is she a positive stroke, 3 years back had hemiplegia and recovered, and now again patient is having a recurrent stroke, you have to tell it's a recurrent stroke. When the patient is being kept as a old case of stroke, 3 months back patient had a stroke, and now they have been kept in the exam phase, you tell it is an old stroke. You tell it is an acute stroke, recurrent stroke, or old stroke. Then you have to tell about the weakness, whether patient is having weakness or hemiplegia or monoplegia. When the patient is having weakness on the left upper limb alone, you have to tell that it's monoplegia. When the patient is having weakness in the left upper limb and lower limb, you have to tell as hemiplegia. When the patient is having facial weakness also, you have to write as facial weakness, and upper limb weakness, you have to write it as facio-brachiomonoplegia. Then you have to tell about the sensory loss, whether patient having right hemianesthesia or left hemianesthesia. These things I will tell later. Then you have to tell about the cranial nerve palsy. The commonest cranial nerve palsy that is associated is commonly seen in hemiplegia is facial nerve palsy. So in facial nerve palsy, you should mention whether it is a human or element. Never forget to mention that, as well as you have to mention right or left. So mostly in the hemiplegia, there will be it's called a human case of hemiplegia. And the upper half of the face is spared, you suspect human hemiplegia, and upper half of the face is also involved. You have to tell us element hemiplegia. First point. Then you have to tell us right or left. So whenever mostly in the clinical, commonly in the hemiplegia, patient when they're having left hemiplegia, they will have left human type of facial palsy. When they're having right hemiplegia, they will have right human type of facial palsy. When there's a element facial palsy, you have when the patient may have right element facial palsy with left hemiplegia. It's called crossed hemiplegia. So when there's a element facial palsy with hemiplegia, mostly it will be crossed because the level of the lesion will be pons. So you have to commonly it will be human and commonly it will be on the same side. So left hemiplegia with left human facial palsy, you have to tell. Then you have to mention about the other cranial palsy also, like gaze palsy. Certain times when you examine the case, acute hemiplegia, the patient may have an eyeball deviated to a particular side, like those things. Like so, at that time, you have to tell whether patient is having gaze palsy. Yeah, those things you have to tell. Then you also have to tell whether patient is having aphasias. For example, patient have motor aphasia, sensory aphasia. These things also you should never forget to mention this exam diagnosis. Also, you have to tell about the other cranial palsies. For example, patient may have dysphagia, nasal regurgitation. Then you have to tell us patient have 9th, 10th cranial palsies. So almost all these cranial palsy points should be coming in the diagnosis. Then you have to tell about the etiopathogenesis, whether it is due to thrombosis, whether it is due to embolism, or whether it is due to hemorrhage. These things you should not forget. So thrombus, embolism, or hemorrhage, you have to tell in the diagnosis. Arterial involvement, whether it is due to middle cerebral artery, or anterior cerebral artery, or posterior cerebral artery, that you have to mention. Also, you should mention whether it is the right side or left side. For example, if it is a left hemiplegia, you have to mention is the right middle cerebral artery involvement in the diagnosis. You have to mention about the cardiac lesion if at all there is. If the patient is having rheumatic heart disease, MS, MR, atrial fibrillation, and then patient developed hemiplegia, you have to write patient is having rheumatic mitral stenosis with the MR, with the atrial fibrillation. You have to mention the patient cardiac other system examination. You have to mention the patient is having chest pain, palpitation, dyspnea, as well as the patient is having pulse deficit, irregular pulse. Then you have to suspect probably patient MS, MR with EAF, then patient developed a left atrial clot and it would have dislodged and it would have produced hemiplegia. And then you have to tell about the level of lesion. The level of lesion may be cortex, internal capsule, thalamus, midbrain, pons, medulla, and spinal cord. Can we tell all those things? Yes, definitely. In the examination, you have to tell at what level the infarct would have occurred and patient would have developed hemiplegia. Then you have to tell about the associated risk factors like hypertension, diabetes mellitus, smoking, alcohol, obesity, hyperlipidemia. So these type of the risk factors also you have to tell. Then you have to tell about the stage of hemiplegia. Stage of hemiplegia. There are 3 stages in hemiplegia: stage of neuronal shock, stage of resolving, and stage of residual paralysis. Patient in the examination, they'll give you a case 2 days old hemiplegia. When you examine, the patient may have hypotonia, left upper limb and left upper limb hypotonia and left upper lower limb hypotonia. When you examine the reflexes, it will also may be absent or it may be just present. So what happened? The student used to tell, oh, this is hemiplegia. You have to tell only it's human lesion. We have to tell it is hypertonia and the reflex will be brisk exaggerated. No, but when you examine patient being in hypotonia, so never don't tell even the patient is hypotonia. Don't tell it as hypertonia. So when you are being given an acute case, examine the tone. If it's low, just mention as a hypotonia. If the reflexes are sluggish, tell that the reflexes are absent or sluggish. But you have to tell in the diagnosis, it is probably the patient is in the stage of neuronal shock. When the patient is in neuronal shock, the patient may not have a hypertonia, spasticity may not be there, the patient will be in hypotonia, the reflexes may be absent. So when the hemiplegia having hypotonia and areflexia, you have to mention patient probably in the stage of neuronal shock. So then the second stage is stage of resolving. At that time, the patient tone will increase and the reflection may slowly, maybe brisk. And stage of residual hemiplegia means in that zone, the patient will full-blown hypertonia and the reflex will be exaggerated. So based on the clinical findings, you have to tell the stage of neuronal shock, recovering or resolving, and residual. So don't have a idea that always hemiplegia means the reflex will be absent like though it will be brisk or exaggerated. Also, never forget to tell about the complications. Mostly, whenever patient of hemiplegia have 9th, 10th cranial pressure, patient may get dysphagia, nasal regurgitation, they will get aspirated. So, hemiplegia patient having cough, fever, suspect the patient probably may be having aspiration pneumonia. So, it will be commonly present in the acute hemiplegia. When the patient is a chronic, 2 months old hemiplegia, the patient may develop bed sores. So, when the patient is given, you are given a chronic hemiplegia, never forget whether there's any bed sores are there. When it's acute hemiplegia, you also try to find any findings for aspiration pneumonia. So always in the exam, you have to tell about the complication. So summarizing, you have to tell it whether acute stroke or recurrent stroke or old stroke, whether it's hemiplegia or monoplegia or facial-brachial monoplegia, whether there's a hemianesthesia, whether if there's a facial palsy, whether it's right or left, whether it's UMN or LMN, tell about any gaze palsies, any other cranial palsies in 9th, 10th nerve, as well as whether tell about motor aphasia, sensory aphasia, tell about whether it's probably due to thrombosis or embolism or hemorrhage, whether it is middle cerebral artery, anterocerebral artery, or posterior cerebral artery, associated cardiac lesions, associated risk factors like hypertension, diabetes, alcohol, obesity, hyperlipidemia, whether what is the probable level of lesion, at what stage the patient is there, and what are the complications that is present. So all these points will be mentioned in the diagnosis and how to approach, how to find out or corroborative evidence in the history taking and examination we shall discuss. So this is a typical diagnosis. What this is probably a case of acute hemiplegia with the left-sided completed hemiparesis with the left to human type of facial palsy, probably in the patient in the stage of recovery due to thromboembolysis probably involving the lenticular straight branches of right middle cerebral artery. You have to mention the side also. So when it's a left hemiplegia, you have to mention the right middle cerebral artery. And the probable level of lesion is the right internal capsule with associated risk factors like diabetes, mellitus, hypertension, without any complications or with any aspiration immunities like those things. So all these points should be there in the diagnosis, and you should now find out the corroborative evidence. This is the way how to write a diagnosis in a case of hemiplegia. So hemianesthesia, how to diagnose hemianesthesia? So whenever you want to, when you are checking the sensor system, so most of the hemiplegia may have hemianesthesia. So when you just pinprick in few areas, you just never ask whether the patient is able to feel the sensation alone. You should ask how you are feeling this side and how you are feeling this side. Whether you are feeling the pain sensation equally on both sides. Then only the patient will tell, no, I'm having some amount of pain sensory loss on the right side, like those things. So never ask a question whether they are able to feel alone. You should also ask whether they are feeling equally on both sides. So mostly commonly just in the exam, when you are starting, you just prick one in the face, in the upper limb, in the body and the lower limb, and always compare on the right and left side. If there is, they'll tell, even though here I am having 100% in sensor pain is normal, here it is only 70 to 80%, that means it is hemianesthesia. So this type of lesion is commonly hemianesthesia, it commonly present in internal capsule level of lesion as well as thalamic level of lesion. So thalamic stroke as well as internal capsular lesion will have a right hemiplegia as well as right hemianesthesia may be there. When the patient is sensor loss on the right side of the face and left side of the face, the left side of the body and the lower limb, you have to suspect medullary stroke or lateral medullary syndrome, probably due to PICA and posterior inferior cerebral artery involvement, and it's called Wallenberg syndrome or lateral medullary syndrome. So patient in the lateral medullary syndrome, patient has sensory loss on same side as well as opposite side of the body, same side of the face and opposite side of the body. Etiopathogenesis. How to diagnose thrombosis or embolism or hemorrhage. So this tabular column is highly important to diagnose whether it's due to embolism or thrombus hemorrhage. Mostly, so certain times students will say it is due to thromboembolic etiology. You should not tell like those things. You have to tell whether it's embolism or thrombosis. So age of onset. So embolism is common in the younger age group when the patient has stroke in the less than 40 years, or you can suspect embolism. When the patient is older, elderly patients, middle or elderly patients, you have to suspect thrombosis or hemorrhage. So, exam, when the patient comes around 60 years, you have to suspect thrombus or hemorrhage. Embolism is very rare. Mode of onset, acute or dramatic onset or stormy onset is common in embolism. Thrombosis will have insidious and hemorrhage will also have acute onset. This means you have to probe the history. What happened on the day of stroke? They will tell. Initially, I had a walking difficulty. I was dragging the feet while walking. Later on, hours together later, then I had a difficulty in grasping the food. Later on, hours together, I had a difficulty in lifting the upper limb above the head. Then I had a facial deviation. Then I developed speech difficulty. Like those things, when they tell hours together, like those things, you have to suspect, it's called insidious syndrome. So you have to suspect thrombosis. When it comes as a bolt of the blow, they tell, I was doing work at the time, I developed hemiplegia and I was having complete weakness left side, upper limb, lower limb, and facial deviation. Then you have to suspect embolism. And likewise, hemorrhage also may have acute onset. They will have full blown hemiplegia even at the onset itself. Then you have to ask about time of when did it occur? That question you should ask. Mostly when it occur in the morning time, you have to suspect hypertensive events are more common in the morning. So you have to suspect thrombosis or hemorrhage. So when they occur in the early morning, 5 a.m., when I just got up and then when I go for brushing or like those things, when I go for outside, I had a hemiplegia, means you have to suspect thrombosis or hemorrhage. So these things are morning time it occurs. But usually embolism will occur daytime, afternoon. Till afternoon I was working over there. I was walking there. I was doing exercise. Then I developed hemiplegia. You have to suspect embolism. Fifth is convulsions is commonly present in embolism as well as hemorrhage. Convulsion is common in embolism also. Then hypertension. Hypertension is common in thrombosis as well as hemorrhage. So hypertension, diabetes mellitus, all those risk factors, atherosclerotic risk factors are common in thrombosis as well as hemorrhage. Cardiac lesion, if there is present or if there is an history of OC pills in females, you have to suspect embolism. So embolism will have some source of embolic phenomena. Recovery pattern. This is also important when they'll tell yesterday he had a hemiplegia. I was not at all able to walk. Now his dramatic recovery is able to walk means you have to suspect embolism. So embolism will have dramatic recovery. Yesterday you will have about 0/5 hour. Next day would be walking comfortably. Then you have to suspect embolism. Thrombosis, they will have gradual or it may remain static. For example, in the patient have, even you are asking history, I had a hemiplegia 5 days back. Initially, I was not at all able to move. Now I am able to move the left lower limb. Now I am able to raise the upper limb. Like those things, when they are telling, then you have to tell it is a thrombosis. Hemorrhage, it may also remain static. What will then? 4 days back I had hemiplegia. Now also it remains same. Also may occur in thrombus. So recovery is gradual or it is remain static in suspect thrombosis. When the in hemorrhage also, the patient may not have delayed or no recovery, or it may worsen Patient may not be conscious initially. Next day he may be unconscious. So these type of worsening clinical picture occurs in hemorrhage. Prognosis, embolism is a good prognosis, thrombosis bad, and hemorrhage is bad prognosis. So again, reiterating the point, the initial history taken is very, very important for diagnosing whether it is thrombosis, embolism, or hemorrhage. So date of onset, time of onset of paralysis. So you have to mention at 5 a.m. or 6 a.m. patient developed hemiplegia, morning. So mode of onset. Sudden onset is common in vascular, infective, traumatic, and demyelinating. Gradual, when there's a tumor, the patient will have developed left hemiplegia 1 month back. Then left upper limb weakness 1 month back. Then left lower limb weakness 1 month later. Like those things, when there's a gradual, you have to suspect any tumor. So cerebral embolism develop in seconds. Stroke develop in seconds. Trauma onset, thrombosis develops in minutes to hours. Hemorrhage very sudden in onset. And usually progress infective hours to days. Demyelinating develops to days to weeks. So I tell what they were doing when is the first question, and what they were doing at the time of onset of stroke. You have to ask whether the patient was sleeping or just soon after rising from the bed. You have to suspect thrombosis during exertion or activity. So patient may say, I was running, I was doing exercise. At the time, patient, I had a hemiplegia. You have to suspect when they are doing any activity, exertion, then you have to suspect embolism. At the height of emotion, certain times the patient, he was having a highly tensed the bank's ears and he was shouting to them, then he developed hemiplegia, means you have to suspect hemorrhage. Subarachnoid hemorrhage also may occur during activity, exertion, or height of emotion. When the patient had a fever, headache, vomiting, and convulsions, and then developed hemiplegia, you have to suspect meningitis, encephalitis, or any abscess. When the patient developed a transient hemiparesis after fits after convulsion focal seizures, you have to suspect Todd's palsy. So, paralysis extends over hours stroke in evolution. Completed stroke within 6 hours, you have to tell completed stroke. Increase in step-by manner. Patient may have recurrent TAA. They will have hemiplegia, upper limb weakness, they will recover. Lower limb weakness, they will recover. And frequently they will do have these episodes of TAA and then leading to fully evolved stroke, means you have to diagnose stuttering hemiplegia, stuttering stroke. So again reiterating, so cerebral thrombosis case will have a middle-aged or elderly, very often hypertension and atherosclerotic. Onset is less rapid than cerebral embolism emergence. Usually stepwise progression, mild headache and convulsion may occur. There may be a past history of TIA, occurs during sleep and soon after rising from bed. Carotid bruit with diminished pulsation also supports cerebral thrombosis. So always never forget to auscultate over the carotid in the general examination itself to find out whether there is any carotid bruit. Also, when the patient have diabetes, mellitus, hypertension, atherosclerosis features, you diagnose it as thrombosis. Embolism is common in females. Patient may have a cardiac disease. Patient may have chest pain, palpitation, dyspnea, valvular heart disease, rheumatic MS, MR, with atrial fibrillation will be there. So pulse rate will may be irregular. You have to check for the pulse deficit, and it will have a dramatic onset, Xiaomi onset. Patient will have full-blown hemiplegia even at the onset, and it will occur mostly during exertion. He was doing some work, he developed hemiplegia. As well as dramatic recovery also. Yesterday you will have 0/5, next day you will be 4/5, 5/5. So headache may not be there. Fits may be there. In embolism, fits may be present. Evidence of shifting hemiplegia may occur. Yesterday right hemiplegia and today left hemiplegia, because embolism will be multiple. It will be a shower of embolism. So that time the patient may have shifting hemiplegia. So evidence of systemic embolism should be there when you want to diagnose cerebral embolism. Hemorrhage patient mostly above 40 years at the height of emotional excitement over minutes to hours, it progresses rapidly. Almost all are hypertensive, headache, recurrent vomiting, convulsions, ICD signs, and unconscious. These 4 points are very important when you want to diagnose hemorrhage. So patient may have headache, vomiting, fits, and unconsciousness, loss of consciousness. Or may so features of LVH, features of atherosclerosis may be present. Conjugate deviation of eyes, cane stroke breathing are common. When there is a SAH, the patient may have neck rigidity. So when there's a spontaneous hemorrhage, if you are suspecting a patient may have pinpoint people, pyrexia, and paralysis. So common site of ICH is putamen, thalamus, parietal lobes, pons, and cerebellum. These are the sites of hemorrhage that's commonly present. Subarachnoid hemorrhage may not have a focal neurological deficit, but patient may have headache, neck rigidity, Kernig signs may be present. This commonly occurs in young adults, known as apoplexy of the young. In subarachnoid hemorrhage, they will have severe throbbing headache. They'll keep her hand over the head and they'll tell that they had a severe headache, and then they will develop deficits. Commonly, they will have cranial palsy. 3, 4, 6 cranial palsy will be there in subarachnoid hemorrhage. So now we have discussed about how to identify thrombus, embolism, or hemorrhage in a case of clinical case, and how to what are the points you have to mention in a case of clinical case of hemiplegia. In the next session, we can discuss about how to diagnose which artery is involved, whether it is middle cerebral artery, whether it's anterior cerebral artery, or posterior cerebral artery. Thank you.